Welcome to Ask the Egg Whisperer. I just finished my Saturday patients and I just thought I'd come on and answer your questions today. So our first question comes from Van. Van is 39 years old from New York. And Van is saying, "Hi, Dr. Aimee. I have a 3-year-old son conceived when I was 35. Naturally and without complications, I miscarried at 6 weeks after conceiving again naturally in 2019. I started seeing a fertility specialist last summer, did all the tests, taking all your recommended supplements. I had a successful IUI in October on my first attempt, but miscarried at 10 weeks. The DNC test revealed a de novo Robertsonian translocation. So then I started my first round of IVF in February. Egg retrieval March 10th. And then I was put on low-dose birth control, went in today for routine hysteroscopy before starting my frozen embryo transfer, and the doctor found a fibroid requires surgery, and my transfer was canceled. That same day, we found out that our 6 day 5 embryos yielded 1 normal embryo and 1 low-level mosaic, both BB. Could this fibroid have been there the whole time? I had a sonogram by my OB a month ago, and all looked good. Any thoughts or advice? Thank you for all you do." So, Van, first of all, having 1 normal embryo at 39, knowing that either you or your partner have a balanced translocation is pretty amazing. So I'm really happy about that. Looking at the question here as far as the fibroid, what I would say is it could be a fibroid or a polyp. And so polyps can grow as you're taking hormones. And so it's possible that it's a new finding. There are patients who can grow polyps very quickly. And I can't say that it's something that was there the whole time and they missed it. So I'm glad they found it. Now that you have your precious embryo, I'm calling them both precious because I do think a low-level mosaic should be given a chance depending on the chromosome if you agree and everyone on your team agrees. But one thing to consider doing before you transfer is perhaps doing some implantation testing. Talk to your doctor about maybe coordinating the fibroid surgery and ERA, maybe all at the same time if they have experience with that. So that's something that I would do if you were my patient here too. This next question comes from Rachel. Rachel is 26 years old from California, and this is what she wrote in. "Hi, Dr. Aimee. I'm 26. My husband's 30. All tests are normal, and we're still considered unexplained. We did our first IVF cycle at the beginning of the year, and we had 6 blasts genetically tested, 5 normal, 1 undetermined. Our doctor recommended retesting the undetermined one, and that also came back normal. Now the doctor told us the genetic testing company reviewed the initial results, and a different embryo has raised concerns and could be abnormal. They said something about the signals. I didn't understand what they meant. Is it recommended to retest that one? How could a normal embryo all of a sudden be questionable? Do you understand what is meant by signals? It's so confusing to be told it's normal, but then later be told it might not actually be normal. Have you heard of this before? What is going on?" So Rachel, there could have been just, the term I'm trying to use is not clear signaling, and that they just couldn't get a clear result. I can't remember, the name is escaping me. Come to my brain. Clearly, I don't read these questions ahead of time. But the answer to your question is yes, but typically they wouldn't release the result unless they actually knew very clearly whether the embryo was normal or not. So that's typically when they say undetermined if they couldn't tell. And so that is something that happens. It's rare. I would say maybe 1% of the time they're not able to get a clear result. So I think that is confusing. It would cause me to feel confused as well. So I would talk to your doctor and then talk to obviously you're talking to the genetic testing company, but if you're not, I would talk to them. And then when you're 26 and you're told that you have all these fabulous, gorgeous embryos, the question is, what is your diagnosis? So I think of things like silent endometriosis. I think of a uterine issue. I'm thinking that maybe there is a tubal issue, like that there might be some sort of fallopian tube motility issue that is just not moving. It can't move an embryo down the fallopian tube. So think about all those things and talk to your doctor about, now that you've gone through the IVF cycle with me, what are the possible explanations for our fertility? And should we do extra testing before we transfer so that our first transfer has the highest chance of working? This next question comes from Sarah. Sarah's 32 years old, and she writes in from Boston. "Thank you, Dr. Aimee, for answering our questions. I'm gearing up for my first egg retrieval, and my fertility doctor is not keen on answering my questions. This is our first IVF cycle after 3 IUIs. I've had 1 biochemical and 2 years of trying. No male factor. I have PCOS. My AMH is 4, all other hormones, including normal androgens. I'm on metformin, taking melatonin and vitamin D along with my prenatals. My follicle count is over 25, and I have a strong response to follidstim during IUI. And here are my questions, 2 of them. Our doctor wouldn't share her hopes for our IVF pyramid. I get that she doesn't want to give false hope, but she would only share what the average response is for my age. Do you have a sense how many embryos we could expect per egg retrieval given our age and statistics? The answer is I can. So 25 eggs at 32, 25 follicles, let's say you're going to get 18 to 20 mature eggs. You'll get, let's say, 15 to 17 fertilized. You'll get maybe around 6 blastocysts. Of those 6 blastocysts at 32, you could have 3 to 4 that have normal chromosomes. Given that you want 2 children, I would estimate that you would probably just need 1 IVF cycle to reach your goals. The next question you're asking is, do you have a sense of how many embryos we could expect per egg retrieval? I think I just shared that. And sorry, this is the second question. My fertility doctor is planning on using a Lupron trigger to avoid OHSS and a fresh transfer, but I heard Lupron doesn't allow for a good lining. Is Lupron and fresh possible? And Sarah, the answer is Lupron and a fresh is possible. After the Lupron trigger, once you retrieve eggs, you're aspirating cells like estrogen and progesterone, and we have to replace those hormones that your body isn't going to naturally make, and we replace those hormones by having you take estrogen and progesterone. It's really as simple as that. So you can absolutely do a fresh transfer with a Lupron trigger. Other quick tips to prevent OHSS: get seen frequently, early, start at a lower dose. Make sure you have emergency phone numbers. Plant-based protein powders, shakes throughout your cycle and start going up as you get closer to trigger and after retrieval. Make sure you have a stool softener on hand so you don't have any poop emergencies. Heating pad is your friend. Tylenol, Motrin for pain and cramps. And talk to your doctor about maybe adding bromocriptine and Femera if your estrogen level is really high. And ultimately, doing a frozen embryo transfer and not transferring fresh is one great way of preventing severe OHSS after an egg retrieval. This next question comes from Bree. Bree is 35 years old from Oregon. Hi, Dr. Aimee. Thanks for all you do. Can you talk about when a natural frozen embryo transfer is indicated? I've had 3 failed euploid frozen embryo transfers with an ERA and increasing medication intervention each cycle. My fertility doctor has decided that maybe a natural FET, since I was able to get pregnant on a letrozole IUI cycle in 2019, but miscarried just before 10 weeks, is probably a good approach. What are the pros and cons of natural, and would you agree with this approach next? I have 6 embryos left, and if I cannot get pregnant, my wife would go next, but she really doesn't want to carry, and I desperately do. Thank you for your thoughts. So Bree, here's what I would consider doing. That miscarriage is probably telling us a story, and it might have something to do with the story as to why this transfer hasn't worked. Ask your doctor if they've ruled out adenomyosis, endometriosis, uterine septum, uterine polyp. Those are the kinds of things that I'm thinking about in a case like yours. If you haven't had a cavity evaluation in the last 6 months or so, this is a great time to do it. I know you've done an ERA test, but maybe doing a Receptiva DX test could probably help your doctor as far as guiding you as to what protocol might be better for you. So in a case like yours with 3 failed euploid FETs, if let's say you don't want to do an extra test like the Receptiva DX test, that's okay. One of the things that I do in a case like yours is maybe try 1 month of Depo-Lupron with a Gestin letrozole, calcium supplement, and NAC. This is just something that I do. And then I would also consider, even though it's 1 miscarriage, I would say I don't want another one. And maybe all this is happening so you can do extra testing to see if you'd be a candidate for adding a blood thinner like Lovenox. These things are not things that, let's say, every doctor would do, but I can tell you that probably 2 to 3 out of 5 fertility doctors would think of these types of things that I'm bringing up to you. So I do think that a natural cycle transfer can be easily done in a case like yours. Well-timed, well-monitored. I think especially if you're having regular cycles, that's a great way of letting your body make more of the hormones rather than you taking them. And if that's something that your doctor wants to do, I would definitely support that. This next question comes from Tiffany. Tiffany's 31 from Canada. Hi, Dr. Aimee. Thank you for answering my question. I'm 31 with DOR. My AMH is 0.47. FSH is 10. My follicle count is 8. I have had 4 rounds of IVF, all with estrogen priming, 2 milligrams twice a day, 1 week before. Femera, this is my first cycle, 5 milligrams days 2 through 6, Metapure 300, Cetrotide was canceled. I had 1 dominant follicle. Cycle 2, Femera, cycle days 3 through 7. Gonal F 450, Luvera 75, 2 follicles retrieved, ICSI. I had a day 3 fresh transfer, it didn't work. Second embryo arrested. Cycle 3, I took Femera, Gonal F, Luvera is canceled because of 1 dominant follicle. 4th cycle, Femera. 7.5 milligrams Gonal-F Luvera started day 5, canceled 1 dominant follicle. What protocol would you suggest? Will HGH help me? The next try will be a flare protocol next, no estrogen. Gonal-F 300, Luvera 75. My clinic suggests against PGT testing and prefers day 3. Do you agree, or should I push for the embryos to continue to day 5 to be frozen as I want a bank? Also, do you advise genetic screening for me and my husband? Okay, Tiffany, yes. So we know your diagnosis is DOR, and my question is why? Why someone at 31 has a low ovarian reserve can be related to genetics and environment, and in your case, probably not your age, although some people are born with less eggs. So at 31, it could be your age. However, you wouldn't think of a 31 as having an issue like this. So I always think chromosome analysis, Fragile X screen for both of you is just kind of my suggestion if you're not going to do genetic testing on embryos. That's just one of the things that I do. You guys have heard stories and people who have been writing in that they go through fertility treatment and then find out later that they have a translocation. I like to learn that stuff as much as I can up front before we start. In a case like yours where you're making a dominant follicle and it seems like you've done it at least 3 times with the 4 attempts that you've had so far, one approach would be the mid-luteal phase start. So talk to your doctor about that and see what they think, because that could be a great way of getting ahead of this dominant follicle creation, as I've seen good results in cases just like yours with that approach. The pros of that approach is maybe a better outcome. The cons, you can't transfer fresh. And for some people, that would be really important. At 31, it sounds like you want to bank embryos. So I would definitely consider freezing. Even if you're not going to do genetic testing, freeze the embryos and bank them so that you have enough for your future. This next question comes from Sarah. Sarah's 34 and she's writing in from Canada. Hi, Dr. Aimee. Love to listen to your show. I'm 34 with unexplained infertility. My FSH is 6, AMH is 1.96, LH is 7, progesterone 77, TSH 3.8, estradiol 117. One of my questions is about my hormone levels and chance of pregnancy with IVF. I just started to check my tubes and possible issues by having an ultrasound done, an HSG. If I have endometriosis, can they be detected by these tests? Also, please let me know how many embryos should I freeze. I want to have 2 children. My husband's sperm test is normal. We have 1 molar pregnancy 3 years ago, immediately after an HSG test. Thank you, Sarah. Okay. So the first question is, if you have endometriosis, can they be detected by these tests? The answer is no. The hormone levels don't tell us if there's endometriosis present or not. Endometriosis can be detected by a laparoscopy. It can be detected sometimes by a blood test called a CA-125 level, which we don't use as a screening test for endometriosis. There really isn't a good blood one. And then sometimes we do a test called the Receptiva DX test, which is a biopsy from the lining of the uterus that can then be analyzed, and then based on what they see under the microscope, we can then tell someone if they more likely than not might have endometriosis. As far as how many embryos you should freeze with your AMH level of 1.96, I would predict, let's just say 15 follicles, 10 mature eggs, 8 fertilized, 3 to 4 blastocysts. You should have 2 normals with your numbers. So I feel good that you hopefully will not have to do more than 1 cycle to get at least 3 strong embryos for your future. However, I always ask myself, how old will my patient be when they're going to have their last baby? And for you, you said you want 2 kids. So you're going to be potentially, let's say, when you're ready for baby number 2, you might be 36 or 37. So you want to make sure that you have enough embryos at that point, because we know that fertility declines and it's harder to get pregnant after. I mean, for some people it could be 34, but the majority of people, 37, it just gets harder. So consider maybe doing another cycle now if needed before you start transferring. This next question comes from Jamila. She's 30 from Germany. Hi, Dr. Aimee. Thank you for your show. My partner and I are trying to conceive for over 2 years and had a miscarriage and a biochemical pregnancy. My cycle is about 50 to 60 days long. I have PCOS and irregular periods, which is why I take Clomid. In my research, I came across a theory that a vegan diet can have an effect on the female cycle. What are your thoughts on that? And since I'm vegan, would you recommend a change in my diet? Thank you. So Jamila, I would just recommend making sure that you're taking supplements. I think vitamin B is important for vegans. I would say you can get that level checked with your fertility doctor and make sure you're not vitamin B deficient. I don't think being vegan can hurt your diet. I just think it's important to get enough protein. And I know people who are vegan know exactly where to get their protein from. So I would talk to maybe a nutritionist and making sure that you're getting all the right nutrients that you need to support a pregnancy. And it sounds like you're being very careful about everything that you're doing. This next question comes from Lee. Lee is 39 years old and writing from the U.S. Hi, Amy. I have a slightly elevated Bcl6, but no, they're endometriosis symptoms. I have a frozen embryo transfer coming up with my only good embryo, but if that fails, I want to take a break from IUI and try an IUI again. I previously did 2 IUIs and had chemicals both times. My first question, is it unlikely for IUIs to work with an elevated Bcl6? I'm doing a month of Depo-Lupron for the FET, but obviously I can't do that before an IUI. I know Femera, which I used in previous IUIs, can be used to lower Bcl6, so should that be sufficient? My second question is, I use HGH during some of my retrievals, and it seemed to help with quality. Can I also use it with an IUI cycle? So Lee, all great questions. If you were a patient of mine, I would suggest that you perhaps do the IUI first. Keep your embryo frozen, because it would be pretty awesome to get pregnant naturally or more naturally with IUI, and then you can save that embryo for the future. However, if you feel like doing the transfer first, of course, I would definitely consider that too. Don't get me wrong, but I like to think about all the options. As far as Femera being used in an IUI cycle, I do think that it could help with receptivity in the lining and potentially with the Bcl6 levels, and it could be sufficient for you. I actually also use Femera during the Depo-Lupron month. So my patients take Depo-Lupron shot, it lasts 30 days, and they'll do agestin, low dose, 2.5 milligrams per day, also known as norethindrone, and they'll take Femera as well, 1 to 2 tablets per day until they start their progesterone. So I use that medication because we know that it lowers Bcl6. I also give patients HGH during their IUI cycles as well. Not for everybody, but in some patients. And for someone who's 39 years old, I think it can make sense for you to take HGH during your IUI cycle. Okay, this next question is from Ellen. Ellen is 33 years old from Olympia. Hi, Dr. Amy. I'm 33 years old. I'll be 34 soon with DOR. My AMH is 0.5. My FSH is 15.8. I have 1 tube due to torsion when I was 16, and I'd like to have 2 children. I've been taking Triniagen, pterostilbene, along with a bunch of supplements for 6 months, and I'm headed into my second retrieval cycle. The first time I had 9 mature follicles with 4 eggs retrieved, 3 mature, 2 untested, but great-looking blasts that were frozen. We're hoping to bank a couple more before attempting a transfer. With so few untested embryos, would you recommend ERA and or Receptiva tests before your first transfer? I'm eager to get to transfer, not eager to pay thousands of extra money for the mock cycle, but if it's going to significantly increase chances of success, I'd go for it. I have to go to a different clinic because my current one doesn't perform those tests. Thank you for any insight. So Ellen, I would. My question is, why did you have the torsion? Torsion most often happens when there might be a cyst on an ovary. So I'm wondering, was that cyst potentially endometriosis? So make sure to get the pathology reports from that surgery and have your doctor take a look at that. And at the time of surgery, see, did they notice any endometriosis anywhere else in your body? If they did, I would say it might make sense to do the Receptiva DX test to see what's going on with that. And with your age and your hormone levels, I would say do the extra implantation test. I think it would just be hard to do a transfer and have it not work and then say, darn it, like I wish I had done them. While it sounds pretty, I'll use the word annoying, that you have to go to another clinic to do it, I would say it might be worth taking that step and doing that first. And then the other thing is, I know this sounds like going backwards, but for me, it's always forward. I would say you could then consider saving these embryos that you have and don't transfer them quite yet, because we know that your fertility levels will be different in 2 years. So this might be the best time for you to consider ovulation induction to help you ovulate from the open side so that you can try and get pregnant without using your embryos. And you can save the embryos for later. So that's kind of one thing that I would consider in a case like yours is, given your young age, you made, you grew 9 follicles to get 3 mature eggs. I would see if we can do that to get the side that has the tube to ovulate and try naturally, maybe for, maybe 3 months or so before you do a transfer. So that's something that if you haven't already thought of, I would think about doing that. This next question comes from April. April's 40 from Texas. Thank you for taking my question. My husband and I have recently finished our initial fertility workup with our clinic, and we were given surprisingly good odds for success, but I'm skeptical. We're both 40 with a diagnosis of male factor. However, my husband's semen does not meet criteria for IVF. I had an AMH of 3.6, 17 antral follicle count, healthy BMI, and blood work, no significant medical history or medications. I've had one successful pregnancy 15 years ago. Our doctor gave us a 60 to 70% chance of pregnancy using IVF, ICSI, and genetic testing of embryos. Do you feel this is an accurate assessment of our odds of success? Or is the clinic just trying to get us to do IVF by sugarcoating things? Thank you. So April, I love the enthusiasm that your clinic has, and obviously they're extremely positive and trying to encourage you to do IVF, but the real deal is when you're 40 years old, no matter how many eggs you have, it's still really hard to find a good egg. You can have 17 antral follicles and get 10 eggs and make 8 blastocysts make 8 embryos that turn to 4 blastocysts and still not have a single embryo that has normal chromosomes because you're 40. So I'll just share with you what I tell my patients, just so you know. I'll call it the real deal in a smart aleck sort of way. So the real deal is that it's really hard to find a good egg for a woman who's 40. It might take several cycles to get a healthy embryo, and it might take using a donor egg or donor embryo if that's acceptable to you. However, given your levels, you are someone who, among a bunch of women who are 40 years old, have the best chance of being successful. Once you have that blastocyst will have a quality that gets assigned to it. That quality will then tell you the implantation rate. Assuming that embryo is normal, then you would have over a 50% chance of pregnancy. So that 60 to 70% chance of pregnancy using IVF, that number is truly once you have an embryo that has normal chromosomes. And you won't really get that number assigned to an embryo or you and your chances until you have that. So that's the hardest part, is certainly if you have an embryo that's really strong, then you have a 60 to 70% chance, even when you're 40. However, the biggest obstacle and hurdle to get over is making that normal embryo. This next question is from Anna Marie, 38 years old, from the Bay Area. Hi, Dr. Aimee. Thank you for answering my question. I've had a long infertility journey with my husband, and I finally made it to a frozen embryo transfer. However, I was dismayed to learn at my baseline that my doctor saw fluid in my uterus. He said he'll watch it for a couple days to see if it'll go away on its own, but otherwise we have to cancel the cycle. What causes this, and how can I prevent it from happening again? I'm 38, I have PCOS, I've had 2 DNCs for miscarriages, plus a uterine septum surgery, never had a C-section. My HSG looked normal a few weeks ago. Also, is there a situation where we can transition to an ERA, or would the fluid somehow skew results? So Anna Marie, if I'm in a situation where I'm already in cycle and I've taken a patient through and I haven't done extra testing, it's a good opportunity to do it. Fluid in the uterus could be from scar tissue, so I think talking to your doctor about doing a hysteroscopy might make sense. Even if your HSG was normal, the fluid could be coming from above, so it could be from fluid in the fallopian tube. Again, even if the HSG was normal, you have to think about that. So when I have fluid inside a cavity for someone who's here for their transfer lining check, not necessarily your baseline, because at baseline, having fluid could be from your period. But at your lining check, if there's fluid, I think of taking Mucinex. I've seen it work really well. I think that maybe that estrogen that we're using might be a little bit too high, and a lot of cervical mucus is traveling up into the cavity of the uterus. So I think about decreasing your estrogen level for next time. But certainly you can also just take advantage of how far you've come. And then from there, you can start progesterone and then do the implantation testing that I often talk about here. This next question comes from Nadine. Nadine's 41 from Germany. Dear Dr. Aimee, thanks for your great show. My DHEAS value dropped a lot within the last 3 months. It went from 4,400 to 32.7 micromoles per liter. What could be the cause? What is a good value when going through fertility treatment? I've read that DHEAS is important for good egg quality. How could I increase my value with nutrition? It's not a prescription-free food supplement in my country. So Nadine, I don't really, I see, it's not a prescription-free food, so you can't take it where you're at. I don't actually worry too much about DHEAS. I don't know that we actually know for sure what normal levels should be. And as far as how they relate to fertility, I think it's actually quite normal to have low DHEAS levels. And I don't think that they need to be a certain level for you to have a good fertility treatment outcome. So I wouldn't DHEAS shame yourself and feel like you're missing out on something amazing. If that was really a thing, I imagine it would be readily available everywhere, and I don't want you to worry about it. This next question comes from Deepti. Deepti is 33 years old in California, and here is what she writes. Hi, Dr. Aimee. In August of 2020, I was diagnosed with stage 4 endometriosis, which damaged my fallopian tubes, and I underwent a surgery that removed cysts, endometrium, and both tubes. Since November of 2020, I went through 4 IVF cycles. We realized I also have DOR. My AMH is 0.38. First and second cycles gave us 1 embryo each, 4 BC, 5 AB, both euploid. My clinic tried a duostem, which gave 0 embryos. After a small break, I went through my 4th cycle 2 days ago. My fertility doctor mentioned 6 follicles throughout the stim phase, but after extraction mentioned that 3 out of the 6 were likely cysts. Is this possible? Of the 3, we now have 2 fertilized waiting for day 6 results. Given my DOR situation, how many more cycles do I have to go through if we want 2 kids? All of this has been emotionally devastating. I'm wondering if going ahead with embryo transfer now and trying IVF in 2 years is better. So let me break this down for you, Deep D. You're just doing the work that you need to have the family size that you want. I am so glad that you have those 2 embryos that have normal chromosomes from your first cycle, and I certainly hope that you will be done with IVF with the results of the 2 embryos that you have from your day 6 from this most recent cycle. I would encourage you to do more IVF now rather than waiting for 2 years, just because we know how devastating endometriosis can be for our fertility. I call it a fertility-threatening condition for a reason. It makes our young eggs act older, it causes less mature eggs and less viable eggs at our current age. So I would encourage you to talk to your doctor about whether they think that you might also have adenomyosis, as this might require you to need more embryos to have 1 single baby. And I also want you to talk to your doctor about what they're doing to prevent more endometriosis from being stimulated as you're going through these cycles. As you're going through IVF and all these cycles, what you're doing is stimulating your endometriosis potentially to grow, and it is very normal to have endometriosis grow through the cycle and not know if it's endometriosis or if they're follicles until you actually get to the egg retrieval and you drain them, and then you find out the hard way that they're actually cysts of endometriosis. So that is not uncommon at all. Talk to your doctor about whether you should do another surgery before you go through a transfer, a hysteroscopy, laparoscopy perhaps. Talk to them about Depo-Lupron preparation. Talk to them about the different transfer protocols that they're going to use to help you with your embryo transfer success. So what you're going through is definitely emotionally devastating. I have all the respect in the world for all patients out there who are going through this, and I can only imagine how hard it's been going through this since the start of the pandemic. Next question comes from Crystal. Crystal's 31 years old from the Philippines. Let me tell you my story. At the age of 15, I hadn't menstruated yet, so I decided to consult an OBGYN from Manila. An ultrasound was done, and from that we got the answer why I do not experience having periods. Dr. Aimee, I was born with Mullerian agenesis. My cervix as well as my uterus was not developed. This was so heartbreaking. This has been the secret of my life, and I've not shared this to anyone not related to me. But I'm seeking help now because at my age and with my relationship with my partner, I want to know if there'll be a chance that I'll get to see kids of my own. I do have ovaries with eggs. Will there be a way by any artificial means that I will be able to reproduce? I have not consulted with anyone. I hope I can finally receive the answer, as I would really like to know if there's a possibility. Thank you and God bless. So the answer, Crystal, is yes. You would have to go through IVF with a transabdominal egg retrieval. That means they put the probe over your tummy and they extract eggs with a needle that way. Then you would prepare the embryos to be transferred to a surrogate. We have seen some great strides in IVF medicine. Until uterine transplantation is something that's done everywhere, that's basically something that you could have done here, but obviously there would be, great obstacles, I imagine, for anyone to get to do that. But uterine transplantation is one way that someone with Mullerian agenesis could carry their own pregnancy successfully. Until that becomes something that's more readily available, using a surrogate is what you would do. This next question comes from Stephanie. Stephanie is 32 years old from Kansas, and Stephanie's question is this. We're diagnosed with male infertility. My husband has seriously low sperm counts due to a blockage of an unknown cause. We found lots of sperm in a testing and have done 2 rounds of IVF. My egg collection was great, but our normal blast rate was well below normal for my age. Over 2 rounds, we've collected 32 eggs, 25 mature, 19 fertilized, 5 blasts, and only 1 PGTA normal, which failed to implant. We used a similar protocol each time, but the second time we added Omnitrope, which did not improve results. What could be the reason for such a poor result, and what would you recommend next? Do you think we have an egg quality or a sperm quality issue? Is it time to move to donor? Would you suggest donor eggs or donor sperm? So Stephanie, in a case like yours, I would really suggest looking at the official sperm reports. When I see stuff like this, I say to myself, why are we here? You're here for sperm. So it seems like this is most likely a sperm quality issue, and frozen sperm doesn't perform as well as fresh. Okay, so even if there's a 3 to 5% chance that using fresh sperm would be better than frozen, I would do that. So talk to everyone again and see, and be like, guys, everyone, come on over here. Let's talk. Can we get everyone on the same page? Can we look at how much sperm we have left and see if we should consider another tessie? See what the possibilities are there. And one thing that you could do is split the eggs half and half. Half husband sperm, half donor sperm, and then see which side performs the best. And then you'll truly be able to make the best decision for you and your family. It doesn't seem like donor egg is the way to go. And then you could also just say, look, I'm not going to make embryos with donor sperm. I'm going to do donor sperm IUIs, and then consider one more tessie fresh and consider a different protocol. So I would say that, you're thinking the way that I would think as well, but perhaps splitting eggs half donor, half husband, and then consider a fresh tessie, that might be the way to go. This next question comes from Becca. Becca's 36 years old from New York. I'm 36 and I lost both tubes and I have endometriosis. We just went through our second egg retrieval and I got 1 egg retrieved. Our first cycle, we got 2 eggs, but those both transfers failed. What can I do? Becca, endometriosis is really, really tough. And, I wish we had more research that went into having better diagnostic tools so that younger women could get diagnosed sooner than later. I wish we had better treatments for women who have endometriosis. And until then, you're doing the right thing. You just keep showing up and you just never know when you're going to get the good egg. But one thing that you might want to decide to do is freezing the embryos, don't transfer fresh, and then ask your doctor if it's possible that you also have an implantation issue because of the endometriosis. Talk to them about doing some special tests like the Receptiva DX test. Talk to them about maybe taking Depo-Lupron first, but you would want to have all your embryos banked first so that you don't suppress yourself too much, because it seems like egg count is an issue. Talk to your doctor about duostim, mid-luteal phase stimulation. Talk to them about using HGH. If you aren't taking NAD as a supplement, for example, that might be something that can help your eggs along with CoQ10. This next question comes from Eternal Sunshine. That's the name she wrote in with. 42 from Singapore. And even if that is your fake name, real name, it's a fabulous name. Dr. Aimee, I hope you're doing well. I've written to you previously and was very grateful for your reply. On January 8th of this year, I transferred 2 embryos with no success. I got my period January 26th through February 4th and started bleeding again on February 12th onwards, which continued for the whole month. My doctor put me on a medication as he said I had a hormonal imbalance, possibly brought on by stress, and my ultrasound scan was normal. After completing the medication, I got my period again, very heavy bleeding, and now I've started bleeding again since April 4th. What could be the reason for this, and what should I test for? I'm 42. I have 2 embryos left without PGT testing because it's not an option here, and I'm feeling really hopeless at this point. I would be grateful for your reply. I have adenomyosis and embedded fibroids, PCOS, and a history of endosurgery. Thank you for helping so many of us on our fertility journey. So Eternal Sunshine, I would say listen to your diagnosis, because the diagnosis is telling you what's going on. You just shared it with me. Adenomyosis and embedded fibroid could be the reason behind your heavy bleeding. So talk to your doctor about doing surgery for adenomyosis so that if they see something like endometriosis that they can remove, that might help with the adenomyosis possibly. As well as the embedded fibroid, you want to know, is that fibroid an adenomyoma or is it a fibroid? So if it's possible to get a pelvic MRI done, that might help clarify things. And at 42, it's not unusual to have wild shifts in our hormone levels that can stimulate a thickened lining when, let's say, you have a high estrogen, and it can make it so that you bleed heavy, bleed more heavier. That's not a word, I don't think. Have heavier bleeding. I think that's more like it. So I would talk to your doctor about doing a hysteroscopy, looking for polyps. Consider medication like Depo-Lupron and see if all that could help before you transfer. This next question comes from Caroline. Caroline's 41 from the UK. Hi, Dr. Aimee. I've been told I have mild adenomyosis. I'm having a laparoscopy and hysteroscopy this week to find out more. I would like to start my first cycle in July. Dr. Aimee, what can I do before then to improve my chances, which I feel are reduced by adenomyosis and a small amount of endo? Would you recommend a test for inflammation if there is one, and any medication to help implantation? My current clinic is recommending Celebrex 200 milligrams 15 days before stim, and I'm already taking serapeptase. I don't want to waste time cycling if my next step is to downregulate. Is downregulating, then stimming an option for me? Thank you, Caroline. So I would say let's start the stimulation first. The laparoscopy, the hysteroscopy, that can come later. The reason why I would say IVF first and embryo transfer preparation second is all those medications that you're going to use for IVF are going to stimulate more endometriosis and worsening of the adenomyosis. So why not stimulate first and then treat it later rather than treating it first and then you're going to make it worse again and then you're going to be like, why didn't I treat it afterwards? So especially because of your age, I would say this is the time to do the egg retrieval cycle, not later. If you've already done the hysteroscopy, laparoscopy, no problem. I would say not a big deal at all, but use the surgical findings to guide you as to whether you should perhaps consider doing a month of Depo-Lupron, for example, before you transfer. So the Receptiva DX test in someone who already has a diagnosis of endometriosis, potentially, I don't know that you necessarily need to do that. However, you might want to consider doing the ERA test and do several IVF cycles to bank several or as many embryos as you can before you start transferring. This next question comes from Erin. Erin is 33 from Walnut Creek. Hi, Dr. Aimee. I love your show. I'm 33 with a 2-year-old, and I've been trying for 4 months for baby 2. My son was conceived first try, and I'm after having my IUD removed. I had my AMH level checked, and it was 1.75. I'm worried baby 2 will be more of a challenge. Would you recommend waiting the full year to see a fertility expert or going now? So, I think that a lot of times as women, we think that the problem is us. And I feel like we miss an opportunity to do a very simple test. It's called a semen analysis. So I don't think it's a bad idea to at least maybe do a semen analysis and see what's going on with sperm. Meet Fellow, MEET, fellow.com/egg whisper is an easy way of getting a sperm test done. So you might want to try just making sure the sperm is good, because if the sperm isn't, then maybe having your husband see a male fertility specialist could be beneficial as you're still trying naturally. As far as your worries and concerns, I think that they're valid, and I would listen to your gut or listen to your ovaries if you're feeling worried or concerned. And I would maybe talk to a fertility doctor to do an ultrasound, talk about maybe doing a fallopian tube test, and then start CoQ10 if you aren't already. And then give yourself a timeline. Say if you're not pregnant by this point, then you might want to take a more proactive approach to getting pregnant for your second baby. This last question that I have on my list to be talking to you guys today on Ask the Egg Whisperer is from Mina. Mina is 32 years old from California, and Mina shares the following. Hi, Dr. Aimee. My partner and I have been trying to conceive for 4 months. A week ago, I was diagnosed with uterine polyps in my uterus, 3.7 millimeters, and the other one 7.6. And one doctor says I should take them out as they might be causing challenges in conceiving. The other doctor is saying no need for that. I'm confused. What should I do? What would you recommend? How do polyps make conceiving difficult? Thank you very much. Love your show. So here's the deal. Polyps come and go. They can, grow during a cycle, and when you have a period, they can go. However, if you think about a little sperm cell, like traveling up the cervix into the uterus, and they see this giant mountain, also known as a polyp, they might have a hard time going over the mountain and into the canyon, which is the tubal ostia, to get into the fallopian tube, to do a meet and greet and give that egg a rose. So the way I think about it, if there's something that might be obstructing implantation, and if there's something there that could potentially cause bleeding in pregnancy, it's a good idea to remove it. Is one doctor right and the other doctor wrong? I mean, it is possible that you can get pregnant with a uterine polyp, but if you're having problems getting pregnant, and it sounds like you aren't yet because you've only been trying for 4 months, why wait for there to be a problem? So I would say put the polyp in a jar and then try, and hopefully you'll get pregnant a lot quicker and sooner with the least amount of complications. Some people think that polyps can cause an increased risk of miscarriage, and I think that might be the case in some patients, and so removing them is something that most IVF doctors do. So thank you guys for joining me on Ask the Egg Whisperer today. I love getting your questions and answering them. You can go to asktheeggwhisperer.com, enter your question there, and then I do my best to answer as quickly as possible. I do have a practice full of patients that I absolutely love taking care of. So obviously my office patients come first, but I always want to be here to answer your questions. So I'm going to go to the chatted questions here, and I'm going to try and answer as many as I can today. So let's see how many I can get through. The first question comes from Bella Mortima. Is 8 follicles cycle day 2 on one ovary okay? I'm 33. The answer is yes. 8 follicles on one ovary for a 32-year-old is fantastic. Next question, can you become naturally with a bilateral endometriomas? If not, how come? And the answer is you can. However, endometriosis can also cause inflammation in the fallopian tube. So if I see someone that has bilateral endometriomas, I always ask, have you checked the fallopian tubes, yes or no? Checking the fallopian tubes is done very easily by a procedure called a hysterosalpingogram. Let's say I'm the uterus and here are the tubes. Here are the tubes. Don't look at my armpits. I might not have shaved them. Yeah, I just said that. So the HSG is done at an imaging center where they put a speculum in the vagina, they open it, they place a catheter, and they push in radiopaque dye. X-ray machine comes over your tummy, and then they usually tell you right away if a fallopian tube is blocked or not. And endometriosis can cause scarring at the end of the tube, and it can make it so that the egg and sperm can't meet in the tube, and that means that the embryo won't be able to march down the fallopian tube and enter the uterus. For a young person who has endometriosis, I always say, warning, warning, fertility-threatening condition, consider freezing your eggs if that's acceptable to you. Next question comes from Jody. Abnormal embryos are being transferred and sometimes making healthy babies. What are your thoughts on this? So my thought is they're not really abnormal embryos. So an embryo could be biopsied at a certain place and be called abnormal when it's really mosaic. Not every genetic testing company will reveal mosaic results to the patients unless the doctor has told them to do that. And so I feel like that is not fair. And so if you guys haven't watched the Nova special called Fighting for Fertility, go to minute 38. You can go to YouTube, put Nova, Fighting for Fertility, and just, well, you can watch the whole thing, of course. But if you go to the timestamp of 38 minutes, you'll start watching a story about a woman who transferred a mosaic embryo that resulted in a healthy live birth. So I suggest watching that for anyone who has more questions about that. Next question comes from Rebecca. Hi, Dr. Aimee. I'm booked in for a diagnostic laparoscopy and hysteroscopy after reading your Tushy method. I've had 2 miscarriages. What should I expect post-op? So hysteroscopy, sometimes you get spotting. Laparoscopy, gas pain, maybe some shoulder and neck pain. Typically, most patients are able to function normally after 1 week. Some people might need a little bit longer, like 2 weeks, to feel completely back to normal. Next question, does Paxil affect fertility? Thank you in advance. The answer is I have my patients continue their any type of medication they're taking that's going to help with their mood. I want people to stay on it. Going through fertility treatment is not the time for people to come off those medications. I have a nice comment. You're amazing. Thanks for all your wisdom during those difficult times trying to conceive. Next question. Do you think low-dose IVF is better for women that are 40 and above? And the answer is less is more when you have less. More is always more if you have more. So getting less when you have more isn't necessarily better than getting more when you have more. So if you have more, try and get more. If you have more, getting less won't give you necessarily more better embryos is kind of my philosophy on that. So if it's not based on your age. So if you're 40 years old and you have 10 follicles, I would try and get 10 eggs. However, you're 40 years old and you have 3 follicles and you want to get 3 eggs, don't use the protocol for the 10 follicle protocol. Use a protocol for the 3 follicle protocol, which would be a low dose IVF cycle. Next question, can you clarify folic acid versus methylated folate for prenatals recommendations? Well, you know that saying, food is medicine. You can get folic acid from your green leafy vegetables. Most of the prenatals that I recommend to my patients have methylated folate in it. I don't know that it really matters which one you take. I just think that getting a prenatal that you feel that you... Some people say that one tastes funny and one gives them an upset stomach. Finding one that you can tolerate really well is very important. Next question, 33 years old, DOR with a translocation, first cycle, 5 eggs, 2 mature. Day 1, they told us none fertilized, but day 5, they said 1 became a blast and the other an early blast. Is that even possible? PGT results came back. It looks like mosaic for chromosome 22. So the answer is it is possible. So when you look at embryos at the fertilization check, sometimes they're called 0PN, and it just means they missed seeing any sign of fertilization. And so that's why it's really cool that we keep embryos and we don't discard them until it's obvious that they should be discarded. Next question, estrase priming due to a lead follicle, 2 menopure, 300 gonal with 25 HH gain or relax. Would you recommend anything differently the next cycle? So I don't see the outcome of the cycle to be able to tell you what to do next necessarily, but one thing that you might want to consider doing is bringing down your gonal and bringing up the menopure. And if you're someone with a history of a lead follicle, I've brought it up before, sometimes starting stem in the second half of the cycle, doing a mid-luteal phase approach is something that I do for patients who have that issue of having a dominant lead follicle. Next question, I have PCOS. I'm trying to lose a few pounds. I'm going to the gym. I replaced breakfast with a protein smoothie. Are there any other vitamin supplements you would recommend that I take? And the answer is yes. So I would recommend, if you aren't taking Ovasitol, you can go to the Theralogic website and get that. I would take that. The other, you just reminded me to take my supplements. The other thing that I would take is NAD. That's like my energy pill. You can clearly see that I have a lot of energy, and it's also my happy pill. So it always keeps me in a good mood too. And if I don't take it, I can tell because I get very grouchy. I can scream at my husband, "Where's my chocolate?" I've been screaming at him, "Where's my chocolate?" for about 2 weeks now. My chocolate is coming today. And I've been screaming at him, "Where are my shoes?" because he bought me the most awesome shoes. And I'll show you guys those shoes. They're coming on Wednesday, and I couldn't be more excited for them. I think you're going to all want a pair too when I show them to you, and you're going to see why I'm buying them. Anyway, so I digress. So the supplement that I was talking about is this one, the True Niagen. It has NAD in it. My face should be on this bottle because I talk about it all the time. I have no relationship with them at all, as I don't with anyone that I talk about, because that's just my personality. This next question is, if you can offer insight. I had a baby in September, incidental finding in December of a dilated IVC. My OB is not concerned. Should I push for further investigation? The answer is yes. I would push for further investigation. So ask for a second opinion consult with a specialist that specializes in IVC. Anytime you feel like your gut is saying, I need another opinion, go get that other opinion. Especially if you have Kaiser Insurance, they have excellent specialists. Next question, 31-year-old. I did an egg freezing cycle. First round, I got 10 eggs, 6 mature, going for a second. Is there anything I can do to ensure more of the eggs are mature at the time of retrieval? So it just kind of depends on your egg count. So if you have 10 follicles and you have 6 mature, that might be the expected number for the follicle count that you had. So I'm thinking out loud here. I would say probably ask your doctor if they think that going up on the dose of medications would help. The other thing is looking at your body size. Women who are curvier sometimes require more medication. So if you're on the curvier side, maybe losing some weight could potentially help get more eggs to grow. That's one option. Maybe considering a heftier trigger shot dose, like more HCG or a dual trigger if they think that could help. So those are some strategies that might help. Someone's asking, have you had a 44-year-old use their own eggs and have success? The answer is yes, I have. Next question. Hi, Dr. Aimee. I've had laparoscopic surgery for stage 4 endo, now preparing for an FET. Would you still use Depo-Lupron? So the answer is, it just kind of depends on the extent of the endometriosis, how much was removed at the time of surgery, and if you have any mood issues. So Depo-Lupron is not a fun drug. It can cause a lot of side effects. So if you haven't gone to my website, draimee.org, go to the blog section and go to the search part, or just search on the website, and you can put in Depo-Lupron, and you'll see my 10 coping strategies for making it through Depo-Lupron. So certainly look at that, and if you're like, I cannot handle even one of those things on that list of 10, no thank you, this is not for me. So the answer is not as clear-cut as stage 4 endometriosis, laparoscopy, then also do Depo-Lupron. I make my decision based on whether I see adenomyosis or not as well. Next question. How successful is egg freezing in your office? I'm worried that my eggs won't survive. So the egg survival rate is actually pretty high nowadays. Once you thaw eggs, usually 90+% will survive the thaw. The issue is the age that you were at when you froze the eggs, and the egg viability has everything to do with your age, genetics, and environment. So knowing your age is probably the best thing as far as predicting what will happen with your egg. Where is the schedule? I love this. Where is the schedule of these Q&As being posted? I am just here, surprise. Just finished patients. I email people ahead of time, so everyone's question that I read today was actually emailed before I came on today. Excuse me. Oh, I didn't mean to scream in your ear. Hello, doctor. I come from the Netherlands. I did my first cycle IVF after transfer. After transfer, a fresh embryo, and after a week, I started my period. I did the second cycle, got 3 eggs mature, 1 was transferred, but I started my period after 1 week. What can be the problem? It seems like maybe you're not taking enough estrogen and progesterone after your egg retrieval. So I would talk to your doctor about the doses, monitoring things to see what they can do differently. Next question is, my CRP is 26.5. Can this cause my 3 miscarriages? I don't monitor CRP levels. I don't know that it causes miscarriages. I feel like probably the most likely scenario that's causing miscarriages in most people is an embryo abnormality, like a genetic cause. But that's why I came up with the ANGEL checklist or ANGEL method. So go to angelmethod.com. You'll kind of go through that list of things that I wrote there. So age, autoimmune anatomy, nutrition, genetic causes like a translocation, sperm DNA fragmentation issues, endocrine abnormalities like thyroid issues, and diabetes, and last is looking at lifestyle. So that's just like the quick checklist of things that you can go through with your doctor to make sure that you've left no stone unturned. Next question from Sarah. Sarah is saying, my AMH is 0.8, FSH, estradiol, AFC, very normal. Haven't gotten even the faintest BFPs. What gives? So it just could still be an egg issue. I would say depending on your age. Okay, I see right there. So what you're saying is you're 33 years old. It still could be an egg quality issue, but certainly look at your tubes, look at your uterus, rule out endometriosis, fibroids, adenomyosis with your doctor. At least talk to your doctor about, have you thought about these things? Have you ruled them out for me? Look at the sperm and make sure you're not sugarcoating it or getting a sugar-coated message, right? So some people are told, oh, it's low, but it's just fine. It should be okay. And that's just not fair to anybody. And then obviously your genetics. So that would be looking at a chromosome analysis, carrier screening if your doctor agrees. Next question. I'm 32. I've had 3 miscarriages. The most recent was tested for abnormalities. I have PCOS and an incompetent placenta. Is IVF the only solution, or can supplements help with egg quality? And the answer is I would try and see based on what is happening, what your doctor thinks could be the possible reasons for the miscarriages, the possible explanations. Given your young age, also look at how many kids you might want. And doing IVF could certainly help preserve your fertility. If you have PCOS, the good news is that you probably have a lot of eggs. And I think PCOS, a lot of people think of it as a fertility issue, but I sometimes see it as a blessing. Not sometimes. I think everything is very, I have, what's the word? It's not, I would say I'm an optimistic person. I'm positive and practical. So I feel like when I have an issue, and I'm dealing with it with a patient, I'm always going to see it in a way that will give us hope and make us feel like we have options. So in a situation like yours, I certainly think that IVF can be one of the options. If you have an incompetent placenta, I think the term is, I hate the term incompetent. I would never, describe a patient in that way. But let's say we have cervix issues. Trying fertility medications and helping you ovulate more eggs when you have PCOS could be quite dangerous because it might result in a multifetal or twin pregnancy. And having 2 babies in a uterus when you have cervical issues would be really dangerous and scary. Next part here. So Sarah from earlier added on, tubes are open, HSG is clear, and semen analysis is very normal. So the way I would think of it is there could be an egg meet sperm issue, meaning a fertilization issue. Look at the morphology and make sure that certainly that is good. It could be an egg quality issue. So, I would say going on birth control pill for IVF or doing, sorry, I'm reading someone else's question and answering this one that kind of got blended together. Ignore, delete. Go back, rewind. I would say for Sarah's question, what I would say to you, Sarah, is look at your age, look at the number of kids that you want, kind of have someone do a fertility projection for you. And since your AMH is 0.8 and you're having trouble getting pregnant right now, it might make sense to freeze eggs or embryos as a way to preserve your fertility. Next question comes from Cassie. I have a blood clotting disorder. Do I have to go on birth control for IVF heading into our 3rd IUI? And the answer is no. I don't use birth control pills for people who have a clotting disorder. Night Nurse is saying, ground flaxseed affect progesterone and estrogen? I haven't noticed that it does. Next question, is 7 follicles on day 3 with an AMH of 1.2, 36-year-old, okay odds for IVF? And the answer is yes. Having 7 follicles is 7 chances of getting a mature egg and a healthy embryo. I'm 5 days before my frozen embryo transfer. Any tips? Yes. So I would make sure you have all yummy foods in the house. Get yummy teas and beautiful candles, and find things that you're going to love to watch or read or do. I tell people to do couch potato exercises 2 days after transfer, which is, wait, where's my phone? Oh, my phone's right in front of me. So let's just pretend this is my phone. So your couch potato exercises means texting, calling people, pushing a remote control. And then I created a website called ivfcabanaboy.com. I'm kidding, I have not. But having someone around to just, make you laugh, for me, it would be my sister. I mean, my husband's wonderful too, don't get me wrong. But my sister sends me interesting pictures, we'll just call them interesting, and just makes me laugh every day, all day long. So you want those people around you. You want your inner circle to kind of know what you're going through so they can rally for you, with you, be there, tailgate. Yesterday I did a transfer and they were tailgating in the parking lot. There was moms, sisters, dogs. I mean, everyone was there and it was just so fun. Even though everyone obviously couldn't come in, we felt the energy and it was lovely. So I want the process of being a fertility patient to be as fun and fabulous as possible. While it involves mental gymnastics and lots of waiting and feeling like you're on this crazy roller coaster, I totally get it. But I still want people to find joy in every experience and every who finds joy in a pelvic ultrasound? Like, that's weird. But with my Egg Whisperer pants, you can. Actually, I'm going to segue here for a second. If you guys haven't seen my Egg Whisperer pants, they're lovely. You can go to eggwhispererpants.com and get a pair for yourselves. So I'm just going to show it to you here. Are you guys ready for this? Your mind's going to be blown here. So here's the crotch, and then yes, there's an opening here. So when my patients wear these pants in clinic with me, they don't have to sit there half naked. I don't like to have people waiting long periods of time. I personally would hate to wait naked for anybody. And it has little pockets in the front. So this is the belt. So you can put, see that? You can put like an ice pack in the back, your heating pad for people who are doing shots. They're comfy and cozy. And you don't feel like you're flashing the whole world, especially for people who are doing transfers. You have all these people you've never met before. You're like, oh, hello. Oh, hi. Oh, wow. Hello. And so I designed these pants with patients in mind. So go to eggwhispererpants.com and you can get yours today. And if you're a patient of mine and I haven't given you a pair yet, you get a pair because you're a patient of mine when you're here. Please don't go to the website. Just tell me what your size is and I'll remember to give you a pair. Okay. Next question. When do you stop supplements, including DHEA, before egg retrieval or egg transfer? And I usually stop by transfer. I don't have many of my patients take DHEA anyways. Next question. I'm 33 with PCOS and all testing came back good. Sperm 2. I did 2 IUIs. Now I'm on my 3rd round. How many more IUIs are recommended? So it just depends, right? What do I want? What's it going to take? Am I willing to do that? And so the thing is, if you're 33 years old, you have to look at how long it's taking you to get pregnant. You might want 2 children. So it might make sense to actually just do 1 or 2 more cycles. And then if that doesn't work, do IVF. What is the difference with microdose Lupron Flare protocol? I've noticed that my estrogen levels are much lower during this cycle, day 7 of stems. My first cycle yielded 7 eggs, 3 normal embryos. Well, that's pretty outstanding. I think every cycle will have a different estrogen level that's associated with it just because of the number of eggs. So it may not be the actual protocol. It could be the number of eggs that you're growing right now. So kind of compare this ultrasound with the last one at the same time and see what's going on. And antagonist cycles do tend to have higher estrogen levels associated with them. Next question, how can I have an AMH of 3.85 and just 8 eggs? I'm 35. Also 1% morphology and borderline fragmentation. 1 reached a blastocyst that was abnormal. Why? So easy. I mean, it's not easy, but I'm trying to make it sound easy and just part of human biology. It's age, genetics, and environment for these issues. It's not your fault. It's nothing that you should feel bad about. It's just part of being human. Your AMH of 3.85 with 8 eggs just tells me the AMH is probably not accurate for what's going on. It's probably a lab variation, so I'd repeat the AMH. Your follicle count will obviously be more telling than your AMH level. So my suggestion would be to talk to your doctor about doing different protocols and ask them what they can do to increase the number of eggs if possible. And what sometimes that includes is not using birth control pills as an example. Ask them what they can suggest for your husband to do to increase the quality of his sperm. So things that you can do are outlined in on my website, ballsmethod.com. And that is a website. You can go to it. Balls, you know how to spell ballsmethod.com. This next question is NAD. Do you take it during pregnancy? And you can take NAD during pregnancy. I don't tell my patients to. And the reason is NAD can make you feel, I'll just call it high energy. And when you're pregnant, it can cause tachycardia already. And so if you take NAD, it's going to make it pretty hard to sleep. How can you replace NAD if you suffer from tachycardia? Easy. So I have found that the liquid NAD causes no tachycardia in my patients. So I'm not sure what the difference is there, but there are companies, I think it's like Quicksilver or something like that, that make liquid NAD. And you can use a lower dose, so start at 50 milligrams and see if you get tachycardia from it, and you probably won't. Next question. I'm 43, completed 2 IVF cycles, both started with birth control, gonal-menopause. Both cycles resulted in 3 blastocysts each cycle, but both they were abnormal both times. So, I mean, the birth control pills probably didn't cause any of those abnormalities, but they might have caused you to get less eggs. So maybe you could talk to your doctor about taking the birth control pills out, adding NAD, adding HGH, and then still trying until you feel like it might be time to start thinking about other options. How many days of PIO do you recommend prior to FET? So it's also about the number of hours. I think most patients are receptive after about 130 hours of progesterone. Next question is, doctor said that my eggs were not synchronized. I had half of them over matured, high 30s, and half in low 10s. He blamed it on the birth control and that I should be forced to menopause. Okay, let's see here. Next question. Hi, I'm 39. My frozen embryo transfer is scheduled for June 28th. Any physical or nutritional advice? So I would say sun, sex, no, I'm just kidding. Sun, supplements, and exercise, and eating healthy. I mean, I want you to just be active. I tell my patients to, exercise, and then you guys know my couch potato rule. My couch potato exercise is for 2 days, but then after that, you can continue to be active. No high impact, high intensity activity is what I tell my patients after a transfer until their pregnancy test, and no heavy lifting even after a transfer. Next question, 36 years old, three miscarriages, all at 6 weeks. Last one was tested normal. I would suggest that you talk to your doctor about ruling out things like antiphospholipid antibody syndrome, adenomyosis, uterine septum, and also look at the quality of the embryos that you have left. And depending on the quality, perhaps consider doing more IVF. I'm not sure if you've done IVF or not. Next question, can doing fertility testing while taking birth control change the results? The answer is yes. So when you take a birth control pill, it suppresses your FSH and your estrogen level. When you take a birth control pill, it can also suppress the anti-Müllerian hormone level. So when I see levels, I always take into account if a patient is on birth control pill when they had their levels checked before I give an interpretation of the results. Next question. Hi, Dr. Aimee. I ended up having another ectopic surgery yesterday. I was able to keep my left tube and I was told I can get pregnant naturally. Would you recommend seeing an RE and exploring IUI or IVF? This was my second ectopic within 4 months. I have 1 viable tube left. HSG was positive for it being open. That's really hard. So, I mean, I'm hoping that the fact that the 1 tube is gone is a good sign. I would look at your age and look at your family size goals and then see whether you think that it would make sense to try IVF now and freeze embryos. You have to look at your fertility tests like the AMH, FSH, estradiol. If there's any sign that your egg quality could be low, doing IVF could make sense for you. Realize we don't alternate ovulation right, left. It's just flip of a coin. So just because this cycle was on the side where the tube was removed, it could stay on that side for 6 months until it flips to the other side. So in cases like yours, I sometimes consider having patients take fertility pills so that you ovulate more than 1 egg. So maybe 2 eggs, so maybe 1 at least will be on the open side to give you the best chance of pregnancy. This next question is from Danielle. Danielle is sharing with us, I'm 37, 1 prior birth, 2 miscarriages last year, and we have had normal genetic screening. I was recently diagnosed with DOR and started my first round of IVF. And the doctor thinks he'll get 6 eggs. He won't remark on how many embryos he thinks that'll make. What do you think? So yeah, 6 eggs at 37 could make, let's say, maybe 0 to 2 blastocysts. So that would be pretty average at 37 with that number of eggs. So I would look at it as, the possibility as maybe needing to do more than 1 cycle before you have 1 embryo, and that would not be unusual. And I would say I don't want you to worry that there's something wrong. If that happens the first time, it doesn't mean that it's going to happen the second time. After a frozen embryo transfer, should you go in and get an estrogen and progesterone check before the 2-week wait? And I don't make my patients wait 2 weeks because that would be torture for me. So for me, it's an 8-day wait. So 8 days after a day 5 transfer, I have patients come in for a progesterone and HCG check. I don't check estrogen levels because I check it before. Next question is, how good is a 4BB day 6 blastocyst? So if a 4BB day 6 blastocyst is a good quality blastocyst, but talk to your doctor about what the implantation rate is for them, because every lab is different as far as what they quote patients, and I think it's important to hear it directly from the doctor. Next question, are better graded embryos more likely to be genetically normal? And I wish that the grading could predict whether an embryo is normal or not. I've had situations where a patient has all these gorgeous embryos and it's the one that was the lowest quality is the one that was normal, and that's really hard to see. So someone's asking, how else do you prepare before 5 days before? Anything? Rest, relax, sun, exercise, eating right, meditation, acupuncture, all of those things can be helpful. Next question from Andrea. I'm 44, my first IVF. We got 5 eggs, 3 fertilized, but none made it to day 5. Now I'm doing one of HGH 1 month before starting my next IVF. Which protocol do you use for HGH? Do you use estrase? So I have a patient get 1 vial of omnitrope, and they reconstitute it once, and they draw up about 1/4 of the vial every 3 to 4 days until they start stim. Next question is from the making of a mommy. I'm 41 and a half, AMH.3, FSH 15, poor responder, want 2 kids, only have 1 bank normal. After 5 egg retrievals, my husband is a balanced translocation. Do we keep doing more egg retrievals now, or should we have the first baby? So that's just so hard at your age of 41 and a half. I mean, the likelihood of even getting a normal with your husband having translocation is quite low. So I'm very impressed that you guys were able to get one. I would call that nothing short of a miracle. So I would start preparing for transfer given all you've been through. And freeze your husband's sperm if you have not done that already. It would be nice if, for baby number 2, you're going to think about other options. You might want to use his younger sperm, assuming that he's around your age. Next question, single mom by choice here, froze 3 PGT normal embryos already, now freezing eggs for the future, hopefully with a future partner. How many eggs do you recommend banking for success? So I'm not sure how old you are, so it's hard for me to know and to guide you. So I have patients go to a website that I send them a link for, and you put in your age and the number of follicles that you have. That kind of predicts close to how many mature eggs you would get. And then you look at the percentage rate of success there, and then I tell patients to take that number and then change the number of eggs so that you have at least 50% or more chance of having the number of kids that you want in that website. Next question, if the embryo split, how long can it take to see the amnion membrane to confirm monozygosity? So what I usually tell my patients is you can usually tell if a pregnancy is momo or mono or mono-di, usually by around 8 to 10 weeks of pregnancy. This next question is, but I've actually seen it come later too. I've had situations where I have had a case where this is a crazy story, long story short, triplet pregnancy. And then it turns out that they all had separate sacs. So that was a great finding, let me tell you. This next question comes from Maggie. 130 hours of progesterone before FET. Does endometrium count? Because I'll be on endometrium for 5 days prior to FET and only 3 days of PIO. Is that enough? So the answer is yes. So any progesterone starts the progesterone clock. Next question. I was diagnosed with chronic endometritis. What is the typical treatment for this? I'm on 3 days of antibiotics, and they're making me. I'm on 3 antibiotics, and they're making me so sick. Any other alternatives? So it just really kind of depends on what the bacterial pathogen is, and that's the beauty of the Alice test. So if you haven't heard of Emma and Alice, that's a test that you can do at any time, and you don't have to do it in an ERA cycle. So it might not be a bad idea to know exactly what the pathogens are that you're treating before you start antibiotics. And I don't know that you necessarily need 3 antibiotics, but there certainly probably is a reason why your doctor is recommending that. So talk to your doctor about why they're recommending the 3 antibiotics and tell them that you're feeling sick and see which ones are the best ones to stop. How long after a DNC can you transfer again? So the answer is I typically have my patients, depending on your situation, come in for a post-DNC ultrasound. I'll look at your uterus, I'll check your HCG level, and kind of predict when your period might start. Based on that, we talk about doing a cavity evaluation before we prepare for transfer and talk about other testing we might do. So it's not unusual for me to ask patients to take birth control pills for about 2 weeks after their period starts so I can have them come in for a cavity evaluation first before we start meds for a transfer. Next question from Somaya. I'm 37 and a half, now 23 weeks pregnant. How long after delivery can I start another egg retrieval? So I've actually started even 6 weeks after delivery for some patients. So I can, every doctor is different as far as what they think is right for their patient. And so I think it's important to talk to your doctor and see what they say. But I've definitely started retrievals very soon after delivery for certain patients who are very motivated to freeze embryos after delivery to store more and bank them for their future. Next question, can vaccinated women be successful making viable embryos? The answer is yes. Almost 100% of my patients are vaccinated right now. I'd probably say the rate is at 95%, and we're making beautiful embryos. The vaccination has not gotten in our way of making beautiful embryos. It has not gotten in my way from IUI pregnancies, from frozen embryo transfer pregnancies, from beautiful embryos and IVF. It's just kept my patients healthy, and it's kept COVID out of the clinic. Thank goodness. Next question. I'm 36 years old. My first cycle was 7 eggs, all 7 mature, 3 PGT normal with donor sperm. So if you want to freeze eggs, I would say maybe do 2 more cycles just to give you some backups depending on what the sperm quality could be in the future. If you're saving eggs for a future partner, perhaps. That's kind of what I'm thinking. Next question, would you transfer an embryo with an egg that has a smooth endoplasmic reticular? I think you're talking about vacuoles, and the answer is yes. So just because an egg has some physical characteristic associated with it doesn't mean that the embryo that's going to come from that egg is going to be bad. It just means, warning, warning, please note there might be an egg quality issue, and be so happy if you get a blastocyst, and once you do, I don't worry about any of those characteristics that the doctors told me about. Okay, guys, thank you again for joining me on today's Ask the Egg Whisperer. I'm going to run home. I love all of you guys. I could be here all day. As you could tell, I can go through all your questions, but I have to end it at some point. So thank you so much for doing all the work that you're doing and for asking all these questions. You're asking all such great questions, and I can't wait to see you guys again here soon. Talk to you guys later. Bye-bye.